and he is going to talk on epidemiology of allergy and asthma. So I request Dr. Ketan to introduce Professor Vedanthan.
Thank you, Dr. Amit, and good morning to all. And it's my great pleasure today to welcome Dr. P.K. Vedanthan. And Dr. P.K. Vedanthan is currently clinical professor of medicine at the University of Colorado, Denver, USA. And he's also a visiting professor at the Christian Medical College in Vellore. Sir was born in the city of Mysore, but since he is interested in global medicine, his work through these years have taken him all over the globe. He did his MBBS from Mysore Medical College, University of Mysore, following which he did his residency in pediatrics from Rhode Island Hospital, the Brown University, Rhode Island. And he did his fellowship in allergy, asthma, and immunology from the National Asthma Center, again, Denver, Colorado. And he has worked all through the globe, like I said, and his passion has mostly been global medicine. A lot of work has been done by him in the field of asthma and allergy. Apart from being a clinical professor at the Department of Medicine at the University of Colorado, he has been the co-director of the Allergy and Asthma Training Program at the CMC Vellore. He's also the co-director of the Diploma Program of Pediatric Allergy and Asthma at Gangaram Hospital and Research Center in Delhi. And he's also the co-director of the Allergy Asthma Certificate course at Bangalore, both at Bangalore and Pune in India. He has received multiple honors through these years. He has delivered the oration lecture at the Indian Academy of Allergy and Annual Conference at Vizag in 2002. In 2014, he delivered the Dr. Shivpuri oration lecture at the Indian College of Allergy and Applied Immunology. And he also delivered the Vallabhbhai Patel Chest Institute Honors lecture in 2015. In 2016, he delivered the oration lecture at the Pediatric Allergy Society of India in Odisha. And in 2016, again, he delivered Dr. Parmesh oration lecture at the Karnataka Respicon. He has written a number of textbooks on the field of allergy and asthma. And again, he is here today to enlighten us with his knowledge and expertise. So good morning, sir, and I welcome you. Over to you, Dr. Vedant. Thank you.
Thank you, Dr. Ketan, for this kind introduction. That was actually a long one. Thank you very much. First of all, I would like to thank Dr. Meenu Singh and Dr. Amit Agarwal for inviting me to participate as a visiting professor at the Postgraduate Institute of Chandigarh. You know, your institute is very, very well known world over, and I'm so happy to be involved in your academic activities today. Thank you so much. And the topic that has been assigned to me today is a very important, at the same time, a very basic topic in the field of asthma, which is epidemiology. So can I go ahead and share the screen now, Amit?
Yes, sir. Yes, sir.
Okay. 1 second. So we are all, most of us are clinicians. So when I see a patient in my exam room, understand the disease or do I understand the patient? I understand the patient, but I don't understand the disease. So for me to understand the disease, what I need is epidemiological research. Very, very important. And that is the only way clinicians are able to appreciate the disease pattern. So epidemiology is a basic pathway to know the characteristics of any particular disease. So we are going to talk about epidemiology of allergies and asthma today. And it is such a wide topic, and also it varies from area of the globe, area in different areas of the globe. So I'm trying to confine it to what's happening in Indian subcontinent today. So if you look at the world population, it's around 7 billion now. But if you look at where is it increasing, where is the population increasing, it is increasing in less developed areas and least developed areas. It is increasing much faster, whereas the developed areas, like what we call as a Western world, it is fairly constant. In some of those countries, it is actually going down. So why should we worry about world population? The reason is, as the population increases, the disease pattern also changes, and disease pattern as well as the prevalence incidence do change as the population changes. So we are going to see a huge increase in several of these diseases in the developing countries more than developed countries. Actually, developed countries may start showing down in the prevalence and incidence of these diseases, whereas developing countries might show an increase. And that's exactly what we are seeing in allergy and asthma, because it's a lifestyle disease. It is influenced by the way the people live, with the with population migration and many other factors that we will be discussing shortly. The prevalence of such diseases are increasing rapidly in the developing world. And that is also called in a different way, LMIC, low middle income countries. India is in that particular category. Now, we know that asthma prevalence is increasing worldwide. In this talk, whenever I say asthma, it is also synonymous with allergies, are going hand in hand and is increasing in worldwide. And we do not know all the causes. We know significant causes in different locations, but not all the causes we know. And as I told you earlier, epidemiological research is very, very important to understand the disease pattern. And if you look at some of the simple things that we take it for granted, like wearing seat belts, wearing helmets, do not smoke, do not drink alcohol, exercise regularly. These are things that we tell our patients, our own family members. These do not look like medical advice, but actually they are. These are what we call as primary preventive measures. And behind each of these advice, there's a whole lot of epidemiological research. Do we have such simple, straightforward instructions to our patients with allergies and asthma? Unfortunately, no, it is not. We do not have such clear-cut, simple instructions, because in the specialty of allergy and asthma, what happened was, it was a typical example of cart being in front of the horse. We did not do good epidemiological research earlier, but there was a lot of concentration on treatment aspect. So we actually came out with the best drug that we have, inhaled steroids, in 1972, without even understanding what the disease was. At that time, I do remember I was doing fellowship in Denver when we did the first study on beclomethasone at the Children's Asthma Research Institute. At that time, the definition of asthma was more of a hyperreactive airways, reversible airway obstruction. There was very little talk about airway inflammation. And there was no epidemiological data that was present at that time to any significant extent. Actually, the epidemiological data started coming in the 1990s after these two studies. One, the International Study of Asthma and Allergies in Children, ISAC, that with a way, very popularly termed, and ECRHS, European Community Respiratory Health Survey for adults. And these started in the early 90s. And out of this, we have got significant amount of data now. So What with this type of data is you are looking at not few patients, you are seeing at thousands of patients at the same time in many different locations of the world. So you're looking at 500,000 patients in one shot. So when you are doing this, looking at a same disease pattern in a huge population, you will understand what the characteristics of the disease are. And what we found, and this is where the ISAC study is happening across the globe. There are the first phase, second phase, third phase. The third phase is just over. So it all started around 1990. And there was another second phase was 2007. And I don't know the exact dates. But basically, it is a worldwide study. India has about 20 centers, and Chandigarh, you are one of them. You are one of the centers for the ISAC Center. And if you look at what's happening to the prevalence of asthma world around, if you look at the first study and the second study in different countries, there has been a significant increase, especially in the Western world or English-speaking countries. There has been a significant increase in these nations, which sort of gave us the impression that this increase was occurring mostly in the developed countries, but in the developing countries, there was not a whole lot of things happening. It was still low. But once the ISAC 3 came in, and what it is showing is actually the overall increase in Spanish in Latino countries, mild increase in the Asian countries except India, and slight decrease or no change in asthma in India, although the eczema has increased, and overall decrease in the asthma ever in English-speaking countries. This is the recent one. And what has been shown is affluence seems to favor asthma. Westernization or urbanization leads to increased asthma. And we know that India is changing. There is a lot of urbanization. There is more affluence. The way people live now are very different. So with this, the disease pattern also changes. So we are having more and more asthma, more allergies now in India than any time before. So summary is allergies and asthma are increasing in prevalence worldwide, but the pattern is changing. Low middle income countries are more affected lately. High income countries are sort of leveling off, or some decreasing numbers are seen there. We still do not know all the reasons. We definitely need more Indian data. It is definitely coming now, but we need more and more of such data. So if you look at some cases that true cases that I saw in India during a lung asthma camp in Sundarbans in 2005, this is a gentleman, probably around 60 years old. And instead of reading through the whole, he's about 52-year-old, sorry, he looks 60. But he suffers from severe asthma, COPD, smoker, and he has been smoking BDs for the last 25 years. And he's trying to puff on that inhaler, which could be empty. And his care is very, very meager. And this is a 14-year-old asthmatic I saw for the first time in a rural camp in near Hyderabad. And according to her parents, she was actually, according to them, she was looking good. I mean, she was doing well, but she actually worried us a lot more because at 14-year-old, she was hardly 4 feet and she was Cushingite, has hirsutism, and she was being so-called homeopathic medicine, which probably was a steroid medication for the past 5 years. And this is a very, very sad case. And another case I just saw in 2017, 3-year-old asthma camp in Kalna, and again homeopathic medication. That is what the parents were told me. And they obviously the child is again short stature, overweight, Cushingoid, all the side effects of systemic steroids. So this is a sad situation. And such cases you will see in every town across India and many other developing countries, is because of lack of knowledge and poor access to qualified specialists, low socioeconomic conditions, and very poorly policed health profession. And this is total quackery. And unfortunately, these things continue to happen. And one of the reasons why it happens, where the asthma care is so poor, is lack of, in addition to the lack of education, if the inhaled route, which we actually promote, is quite unpopular in some of these village levels. They would like to take medications orally and they do not like inhalers. So this is something we need to be aware of and need to be sort of impress upon our patients as well as the health professional, especially the public health officials. And there's quite a bit of social stigma associated with this type of issues, especially in girls and young women. Now, the prevalence of asthma is, according to the studies that have been shown, poverty by itself does not increase the number of asthmatics, but actually it makes the asthmatics much more severe because they are there because of just the reasons I told you, due to poor access, lack of education, and not taking the medicines properly. Very, very little prophylactic care and environmental factors. All these things are one of the reasons for the high severity of the asthma. So this was a survey done of several clinics in different nations in Asia and Africa. Was what it showed was, again, the short-acting bronchodilators, inhaled bronchodilators, were used as a primary drug, more like 100%, whereas inhaled steroids were only used in about 50% of the patients in this situation. So there is quite a bit of lack of proper care in spite of all the knowledge that has been sort of spread around. Still, it's not practiced yet. And the increased severity of the asthma is characteristic of a poor family with asthma, more than high prevalence. Now, the other factors of the cost of the inhaled steroids is another issue that we need to be aware of. Although the cost of these medications are less in India, still it is a factor that can sort of affect the usage of such medications. So if you look at the WHO access to essential drugs, it actually in India, it's about 50 to 80% is not bad. The pharma industry has done a good job in bringing out all these excellent medications, but still the cost factor is probably could be a barrier to a particular portion of the population. And I think the government now is coming out some sort of a Ayush plan, I forget the name, I don't know the exact name of it, which is helping people to get these medicines at a much discount or free. But these details we need to be aware of. I'm not very, very sure about the details of those plans. And some of the disturbing stats in low-income countries is most of the medications that are sold for asthma are bronchodilators, not inhaled steroids. And most of the medications are rescue inhalers rather than prophylactic maintenance medications. So these are all issues that we need to be aware. So asthma and definitely affected by socioeconomic status. more severe asthma occurs in poorer sections of the population. There is very little prophylactic care, and the inhaled steroids is still a major issue. Even after 5 decades after it has been discovered, still is not used to the extent that it should be. Cost is also a factor here. If you look at the different studies that have been done in India, it has been done for several years, but only recently the data has been much more significantly present. And Dr. Jindal did the study in 2004. The prevalence was 2.4%. And Dr. Paramesh did a study in Bangalore, where the prevalence was, this was mostly in the hospital-based study, it was 6 to 29%. So these are studies that show that the prevalence can vary from place to place and depending upon the factors. So we are collecting data in from different parts of the India at all these different centers as shown in this diagram. And this was an interesting study between allergy profile between USA, published in 2016. What it showed was, if you look at allergic rhinitis, here in the left upper corner, Indian subcontinent has almost like 100 million patients, and that is almost equal to the total number in Europe and US combined. And interestingly, although the Indian population is 1,022 million, almost 300 million people are middle class, which is equal to, very similar to what we have in US. And if you look at the number of allergic rhinitis patients in India and USA, actually the number of patients are increasing in India compared to the Western countries. It is actually increasing. The rate of increase is much more compared to the ISAC 1 and 3. It is showing a decrease in the US, whereas significant increase in India. If you look at the expense, how much of money is spent on allergic rhinitis alone, in the US, it is a huge amount of money is being spent. It is actually more than the total healthcare budget of India on one drug. This is several billions of dollars are being spent. So probably because the patient in India does not consider allergic rhinitis as a very significant problem. It's more of a trivial issue to an Indian patient. Until asthma sets in, many of these patients with allergies, with just simple upper airway allergies in India, do not seek much medical attention. Whereas once the asthma sets in, definitely they seek medical attention. And these are all the different impressions of what they have about patients' awareness. If there's a cure for asthma, these are all the different impressions, like about 26%, almost 30% don't know that there is they don't know anything about it. Another 35% think acupuncture, yoga will cure it. So there is a lot of lack of knowledge, especially among parents. This is actually the parental knowledge of asthma. These are all the children, and the parental knowledge is quite poor. The disease burden in India, it is increasing in children, but not a whole lot in adults. Same pattern here. If you look at the disease burden in India, a very, very interesting study was done by Dr. Salvi, published in 2015, Poison study, where they looked at a huge number of patients, almost 204,000 patients, visiting their primary healthcare practitioners in single one day point prevalence study. Very, very interesting study, which showed that the most common reason to see a doctor on any one single day was respiratory. This is overall general, both adults and children included. 51% of patients came to see the doctor in a single day they were all respiratory reason. And in pediatric, it was 65% respiratory, and obstructive lung disease was the most common. So what this study showed was the most common reason why patients come to see the doctor is in origin. And if you look at allergic rhinitis, same story. There is a significant rise in the prevalence of allergic rhinitis. It is running anywhere between 18.6 to 23% in ages 13 to 14. And even at the age of 6 to 7 years, it has gone up significantly. Whereas in adults, it is still around 3%, but 65% of adults who have asthma have allergic rhinitis also. And atopic dermatitis is still low, but recently definitely has been showing an increase, especially in certain areas like in Kerala. So the food allergy is also showing an increase, but the interesting thing is it is more sensitization rather than true allergy. Sensitization is based upon the patient is not having any symptoms, but the test shows that there is a presence of IgE antibodies. And this was shown by the Probable study by Dr. Mahesh group in South India, in Mysore. But if you look at this, any food, if you look at the upper column under India, it is 26.4%. So very high sensitization to any particular food in India, whereas allergy is still only 0.11%. So there's a huge amount of sensitization and very little true allergy, which sort of makes us suspect whether it could be false positive type of reaction. Because when you have higher IgE, the immunocap can be false positive. So it is not a good test to do a screening immunocap especially for foods, especially when you have high IgE. And Indian population have their average IgE is almost double than what you have in the West. It's almost like 320 is what is the average Indian IgE is. So the serum IgE, total IgE is quite high in Indian population due to various reasons. And it could be directed against the carbohydrate component also. And it could be due to parasites, and it could be due to some non-specific changes too. So immunocap may not be the best test to do food screening, although in this particular study, it was the immunocap that was done. And if you look at the history, very, very few people had true allergies, but they had a lot of sensitization. There is also another theory that is what we call as a second wave, and that happened with inhalant allergies too, where the sensitization occurred initially much higher compared to allergies. And once the sensitization occurred for a while, then the allergies seem to set in later on. And that could be happening with food allergies in India. So in future, we may see more food allergies in India, rather not just high sensitization. And this again, a study done by Dr. Mahesh, where they went to the same school and looked at the self-reported wheezing and physician-diagnosed asthma. From 1998 to 2004, it has actually increased significantly by about 10% every year, almost 50% increase in about 5 years. Child asthma cases doubling in Pune, reported again in from Chest Research Foundation against school children. So again, doubling in 5 years. So about 10% every year. So that is a significant increase. And the reason for that are several multiple ones. So multiple factors could be involved in overall increase in asthma and allergies. And food sensitization is increasing fast, and whether it is the second wave, we are not sure. But the way people in India are living, the type of food they are taking, and the type of activity they are involved has changed significantly. Very few people walk now. They all want second two-wheelers or four-wheelers. So there is more obesity, and people have a lot more disposable cash. So they tend to eat outside. And there are also a lot of refined food. So the way people are eating is very different. And that could be all reasons why the prevalence of food allergies could be on the rise. If you, there are multiple factors involved in the causation of asthma, from right from the beginning on the top, environmental tobacco smoke, and outdoor pollution, especially ozone, and several different chemical fumes, sulfur dioxide, nitrogen oxide. Mold is another major issue. Mold is a very strong component of being an etiological factor for any type of respiratory issues. Even though you may not have allergy to molds, just a moldy environment causes more respiratory problems. Cockroach is a very major allergen for causation of asthma, just like house dust mite is. So especially in the US, in the poorer sections of the population living in downtown areas, there is high prevalence of asthma mostly due to dust mites and cockroach infestation. And pets could be sort of a two-way. That means having a dog seems to be more protective against development of asthma, especially during pregnancy in the first 2 years of life, what we call as a window of opportunity. And that has to do with the hygiene hypothesis. And traffic-related auto pollution, especially diesel exhaust fumes, is a definite causative factor for allergic inflammation and asthma. Certain pollens definitely cause more asthma. Breastfeeding seems to be protective, especially prolonged breastfeeding in non-atopic asthma seems to be protective, not in atopic asthma. And close contact with animals, and especially cow dung, seems to have some protective function. Microbes, like if you have just a simple common cold, virus is quite asthmogenic, more than RSV. So viruses cause significant asthma, whereas bacteria do not. Biomass definitely causes significant COPD, and there is some question whether it could also contribute towards asthma. And under microbes, there is also a possibility that children who are delivered by cesarean section, they have a higher, 20% higher incidence of allergies and possible asthma, possibly because of the lack of exposure to the vaginal bacterial flora at birth, and that is in hypothesis again. Antibiotics is a little bit controversial. There is always an issue about giving a broader spectrum antibiotic, especially in the first year of life, can cause more allergies. It's a little controversial. And this is a figure that a lot of people have seen. This is due to biomass. This is a worrisome picture where the mother is spending several hours. You know, she spends like 4 to 5 hours with the child inside the house, doing this cooking using biomass, and inhaling all this particulate matter can cause significant obstructive lung disease, COPD. And this is one of the most common reasons for COPD in non-smokers. These women develop COPD by the time they are 25, 30 years old, and this child will get significant number of lower respiratory tract infections. And this was a stove that was produced as an intervention measure. It is called EnviroFit stove. It is actually, this is in my house. This is our housemaid in Mysore. This is several years ago. I bought 3 of these stoves, and this stove is made out of material where it sort of heat. The material conserves the heat so that even if you use firewood, you use 60% less. It produces very little smoke and seems to be quite efficient in that way. And interestingly, this stove was developed in the same town where I live at Fort Collins, Colorado, at the Colorado State University, and it was supported by Shell Company. And this is the type of traffic pattern that we are all very familiar with in India, where you have this highly polluted atmosphere due to particulate matter, due to diesel exhaust fumes. This type of atmosphere can definitely tilt the balance. If a child is already having some allergic inflammation or more prone to allergies, diesel exhaust fumes can potentiate the allergic inflammation. And many of these children who have allergic rhinitis develop asthma because of this type of environment. So the progression of allergic disease, or what we call as allergic march, will be much faster in this type of environment. And as if you know that Mr. Diesel, Diesel is named after one Mr. Rudolf Diesel from Germany, who actually had nothing to do with all the adverse effects of diesel that we see now. He actually made diesel for his father's print shop, this fuel, and that is how the name diesel came. The important thing about diesel is it produces 1400 times more particulate matter compared to petrol engines. But you cannot make it out with the newer cars that are produced now, because you cannot figure out whether it's a diesel car or whether it's a petrol car. Before you could, if you sit in a diesel car, it used to be hotter, and also it produces very thick smoke. Whereas now the type of cars, diesel cars, you cannot make out. They do not produce all that black smoke at all, which actually is more dangerous because it produces submicron, much smaller particles, and these particles they go directly into your smaller airways. And you cannot figure out whether this is a diesel car or a petrol car. And diesel actually potentiates, as I told you, allergic inflammation. The prevalence is definitely higher in children in Bangalore, according to Dr. Paramesh's study, especially with the combination of heavy traffic and low socioeconomic conditions. The prevalence of asthma is much higher. And this is showing urbanization, increase in the automobile numbers, as well as industries, definitely has contributed to increasing asthma from 9% to almost 29% in about 20 years. And this was a study published by Dr. Salvi Chest Research Foundation, and compared who is at a much higher risk of inhaling much more polluted air. Obviously, it is the motorcycle, and it is not unusual in India to see the whole family going in one motorcycle. They are going quite happily, smiling, but they will be inhaling very, very dirty air. And sometimes the motorcycles will stand right beside the bus, which is also spouting out all that smoke fumes full of polluted material. And the same thing is true for the bus driver, health status of traffic policemen, and there is quite a bit of oxidation, that the oxidative process that goes on in their respiratory tract. And BDs is another issue that we need to be aware of. And actually BD compared to cigarette has 7 times more nicotine, is much more addictive, and it is also exported. In the US, it is available in different forms, in vanilla flavor and all that, and it is marketed as if it is safer than cigarette. It is unfortunate, but that is how it is being marketed. Especially younger teenagers get hooked onto the BD in the foreign countries. And this is what show the PM10 mass inhaled from cigarettes and BDs. BDs is the highest. Mosquito repellent, you have already, I'm sure you have seen it in other meetings. And what it shows is mosquito repellent coils also produces a huge amount of, and it is almost equal to about 75 to 100 cigarettes. And we all have used it. Whenever the guest used to come in the house, we say, oh yeah, it's a good thing, you know, it will keep the mosquitoes away. We will put this coil on in your room. So it is sort of sad that the guest was inhaling all this type of particulate matter, especially with the windows closed. With the windows open, it will be a lot less. So such coils should not be used anymore. And mold, a lot of Indian homes have water leaks, especially because of the way the construction, as well as the rainy season. And mold growth actually is pretty deleterious effect on the respiratory tract and actually causes asthma. And Diwali is a very popular festival we have. Every household is involved, but it causes significant amount of pollution. A lot of SO2, NO are liberated during the fireworks. And this is how India looks on a Diwali night compared to a normal night. It is a picture taken from the space from NASA. And it is amazing how much, how Diwali celebrated across, right across, through rural area, urban area, all over across India, except a few, that the desert portion around Rajasthan. Except that, everywhere it is celebrated and causes significant respiratory problems and other accidents too. So India has a huge burden of obstructive respiratory diseases. The environmental factors are very conducive, and chronic respiratory diseases, in particular obstructive airway disease, are definitely going to increase in the future because of the type of environment. So few words before we close about rural and urban scenario. So in the rural area, there's a lot of biomass, lot of BD that are smoked, poorly ventilated homes, lot of COPD, less atopic sensitization, little less asthma, whereas urban areas, there is a lot more allergies and lesser COPD. And seems to have, we did a study where we looked at the childhood sensitization in rural and urban children in South India. Study was done in Mysore, which is the metro area, and a village of Vinoba, about 40 kilometers away. There are only about 700 people in that village. And this was was to determine the prevalence of asthma, hay fever, allergen sensitization, eczema in rural versus urban children. And what we found was very interesting. In the rural locale, there was a lot less allergies, lot less asthma, less allergic rhinitis, very, very close animal contact. And in the urban areas, there was at least 6 times more asthma and allergies, and very little animal contact, no regular cow dung usage, whereas 95% of the house, the village huts used cow dung. My job was to collect the dust for endotoxin determination from the village homes. So where I spent this, although I was born in Mysore, which is definitely like a much bigger now, like almost like 1 million population. When I was there, it was about 300,000. So I was not exposed to rural living at all until I did this study where I was able to spend quite a bit of time with the villagers in their huts. And I found that using cow dung, it actually worked to keep the houseflies away. And we collected dust from their houses. The villagers were very happy to give me the dust because they knew it was good. We brought it to National Jewish Hospital, measured the endotoxins level, and the endotoxin levels, which is an indirect measure of microbial exposure, was much higher in the rural locale and seems to have a protective role in the against allergic sensitization and asthma. And also statistically, the regular cow dung usage seems to protect against wheezes. City home and a rural home, inside, cows inside the house. They had a bedroom inside. So the contact was very, very close human contact with animals. Cow dung use, all over the place. And this is a cow dung that was right near in Viloba as well as near my house. So Dr. Andy Liu, professor at National Jewish Hospital, who was my associate who did this study, I asked him, from India, what do you want? Do you want me to bring some sandalwood articles or shawl or what? He says, don't worry about it, PK. Just bring me 2 cow dung cakes from India. So I thought, oh, this is unbelievable. He wants cow dung cakes. Okay. I went to the next street, and that is the tree. I picked up 2 cow dung cakes, hid it in my luggage, and I brought it to Dr. Andy Liu and gave it to him. And I just asked him, what do you want to do with it? He said, I'm going to burn it. I'm going to measure the ambient endotoxin. So that is exactly what he did with the cow dung thing and found. And I think he published a study on it later on. And this is a very, very interesting slide. And this is actually a slide which promotes the least allergy, because what has happened here is this particular hut is, it is not only the living room, the kitchen, a dining room, as well as a bedroom. On the side, it is bedroom for the cattle. On the top of that bed, the household, the man of the house also will sleep there. And right here, this is a lady who is breastfeeding the child. And this is a prolonged breastfeeding, exclusive breastfeeding. So all this type of environment and their family lifestyle promotes least allergic sensitization. Whereas when you go to about 20 miles away in an urban area like Mysore, where animal contact in the house, we always use soaps, especially now with all this COVID thing, everybody is using this antiseptics all the time, 25 times a day. And all these things will interfere with the microbial exposure, promotes the allergic sensitization, so promotes Th2 pathway. This is the hygiene hypothesis. So this will sort of bring an end to my presentation. Just to tell you where we are allergy-wise, we used to be pretty low. We had only about 200 allergists about 15 years ago. Now we are up to almost 1,000 because of all the different training programs. And still, if you look at the ratio, it is one allergy specialist per million population, whereas US has about 20, almost 19 allergists per million population. There we have a long ways to go, but it's a lot better than before. I thank you once again for your patient hearing. I appreciate your patience. Any questions? I'll be glad to